I'm Dr. Timothy Brown. I'm a board-certified obstetrician and gynecologist and have been in mostly solo private practice for more than 25 years. I've been pretty much immersed in various aspects of health information technology over the past 3 years. I've been implementing an electronic health record in my own office for more than a year, and I have a master's in medical informatics from Northwestern University. This presentation is a focused and shorter version of my presentation on electronic health records, government incentives, and meaningful use. These are pertinent acronyms in health information technology, or HIT, that have become sufficiently common that their full names tend not to be used. The government incentive payments we will be discussing come from the HITECH Act. This is the Physician Incentive Program. Medicare will pay $44,000 over 5 years based on a maximum of 75% of allowed charges. In other words, the first-year payment of $18,000 will be paid only to those having a minimum of $24,000 in allowed Medicare charges. Hospital-based physicians are not eligible, defined as providing at least 90% of their services using site of service codes 21 and 23. The Medicaid program will pay more, but requires at least 30% of the practice, 20% for pediatricians, be Medicaid. Failure to demonstrate meaningful use of a certified EHR will eventually result in decreased reimbursement. And as Medicare goes, private insurance is likely to follow. Since meaningful use requires a 90-day attestation period, the latest certified EHR can be implemented and still qualify for the full incentive is October 1st, 2012. Use of certified software is required and simply assures you that it is capable of meeting the requirements of meaningful use. These are the stated goals of meaningful use. These are inarguably good things to do, but as usual, the devil's in the details. For Stage 1, there are 15 core requirements and 5 menu requirements. Let's start with electronic prescribing. Start with your allergy list and a medication list for 80% of your patients, which might require that you do a medication reconciliation. CPOE means that 30% of the time you order the drug through the EHR. Then that should generate a formulary check occasionally, as well as a drug interaction check. Finally, send 40% of your prescriptions electronically, as opposed to a written script or fax or phone call. You are now a third of the way to meaningful use. Next, you need to enlist your staff to do a few basic things, most of which they likely do to some degree already. At least half the time they need to get the 4 demographic items: language, gender, ethnicity, date of birth, as well as height, weight, blood pressure, and smoking status. They should be able to get your recalls out 20% of the time. Finally, make sure they get your main labs in to connect for electronic delivery of your lab results, which will then download directly in a structured format. You are now more than halfway there. A certified EHR should be able to do a number of things without much additional effort on your part. Just get the data in. It must be able to send data to an HIE, an immunization registry, or public health agency. Whether they are able to accept it is their problem. You should easily be able to generate an electronic copy of a chart, which incidentally is an EHR HIPAA requirement, as well as generate transfer or referral care summaries. Finally, you should be able to search for and generate a list of patients with a particular condition, which could be as simple as a list of current pregnancies in an OBGYN office. In its wisdom, the government wants us to provide half of our patients with summaries of their visits. You will find a patient portal in any certified EHR, which will allow the required 10% of patients to access the results. And this is clearly also the easiest way to make their visit summaries available. Security and privacy concerns may limit the usefulness otherwise of the patient portal. The final requirements simply cannot be managed without more active involvement from the provider, and most are core requirements. The risk analysis is simply a reinforcement of standard HIPAA requirements and should be done periodically in any event. 80% of the patients will need problem lists, which cannot be appropriately delegated. The certified EHR should have a number of CDS options to choose from, and likewise, the CMS e-measures will need to be reviewed and the appropriate ones selected before turning things over to the EHR to collect and report the proper data. For patient education, decisions obviously have to be made regarding the type and quality of any educational materials used. And that's it. Simple, right? The next step is to make sure you are registered on PACOS, and then it costs nothing to register for meaningful use, even if you ultimately decide against it. The two government reference are really quite well organized and provide a wealth of information. High-Tech Answers I have found particularly useful. Physicians can sign up for their virtual learning center at no charge. I will be happy to take questions and can be reached through my website at timothybrownmd.com. Thank you for listening.